Good afternoon. Thank you all for joining the JMHCP Implementation Science Checklist webinar. We're going to wait about 1 minute to allow others to log on. Good afternoon. Thank you so much for joining the webinar. Today, we're going to be talking about some tools that were developed for the Justice and Mental Health Collaboration Program, which are implementation science checklists. So we're really trying to support how to implement and sustain evidence-based practices over time. Today, we're going to do some introductions. We're going to present on some content on implementation science and the implementation science checklist. We're also going to have a roundtable discussion with the site from Fairfax County that we've invited to speak today. Then we'll have questions and answers. So if you have any questions, as you go along, you can feel free to do it through the chat box or the question and answer, and we will get to those after the presentation content has been completed. So today we have as our speakers, Lisa Potter, who is the Fairfax County Director of Diversion Initiatives, which includes the countywide Diversion First Initiative and the Opioid and Substance Use Task Force. Her work spans multiple systems, including health and human services, public safety, and the courts. She has worked for Fairfax County government for over 25 years in various clinical and administrative positions. Lisa has extensive experience in data analysis and evaluation, strategic planning, program development, and cross-system services. We're also joined by Dr. Faye Taxman, who is a university professor at the Schar School of Public Policy and Government at George Mason University. She is a health service criminologist. She's recognized for her work with the development of seamless systems of care models that link criminal justice and other healthcare and other service delivery systems and re-engineer probation and parole services. She has conducted experiments to examine different processes to improve treatment access and retention, to assess new models of probation supervision consistent with the R&R framework, and to test new interventions. She is the principal investigator for the Justice Community Innovation Network, or JCOIN, Coordination and Translation Center. And I am Sarah Wurzburg. I'm a Deputy Division Director for Behavioral Health at the CSG Justice Center. I oversee our training and technical assistance to federal grantees, which includes the Justice and Mental Health Collaboration Program, as well as Second Chance Act programs focused on behavioral health and housing. I also oversee our community responder work. And lastly, we are joined by Laura Yeager, who serves as the Director of Correctional Health and Human Services for Fairfax County, Virginia Sheriff's Office. She came to the Sheriff's Office with the goal of developing a medication-assisted treatment program and wraparound reentry services at the Adult Detention Center as a response to the opioid crisis. Prior to working in public safety, Laura spent over 30 years in behavioral health services focused on developing major resources resulting in innovative systems change. So the Council of State Government is a national, nonpartisan, nonprofit organization that brings together the power of a membership organization serving all three branches of government. We also support policy and research expertise for solutions to address public safety, public health, and strengthen communities. Part of how we do this is bringing people together. This webinar is one example of that, trying to think of key topics for the field and trying to bring people together. We help to drive original criminal justice research forward, build momentum for policy change, and provide expertise through our training and technical assistance and support to jurisdictions around the country. We have a number of goals. We try to break the cycle of incarceration, advance health opportunity and equity, and use data to improve safety and justice. So I think implementation of evidence-based practices really does cross all of these areas in order to better support additional options to increase public safety and public health. This was developed as part of the Justice and Mental Health Collaboration Program. The JMHCP, as we call it for short, is grants that are provided from the Department of Justice's Bureau of Justice Assistance directly to states, local governments, federally recognized Indian tribes, to address responses to people with mental illness and co-occurring substance use disorders in the criminal justice system. One thing I will note is if this is the type of interventions you're looking to do, there is an open solicitation. We can share information in the chat about that for JMHCP for fiscal year 22. So we would encourage you to check that out. The funding for this webinar and the Justice and Mental Health Collaboration Program is through BJA, as I mentioned. BJA supports grants administration and criminal justice policy development for state, local, and tribal justice strategies. BJA works with communities, governments, and nonprofits to reduce crime, recidivism, unnecessary confinement, promote a safe and fair criminal justice system. So now we are going to get to the meat of it with the presentation content. I will pass it to Dr. Taxman to kick us off.
All right. Thank you very much, Sarah. I greatly appreciate being here today and talking about one of my favorite topics, which is implementation science. And I know for some of you that might be rather boring, but in fact, it offers a way for us to rethink how we put in place grants, new innovations, and basically sustain efforts. Next slide, please. So the nice thing about implementation science is it deals with all of the issues like how do we change existing programs, policies, practices, and how do we study this change? And that's important because, very little of the research literature really talks about the effectiveness of different change strategies. In other words, how do we do this? And to think about interventions that might occur at the organizational level. And when I mean that, I mean the places that you work and the partners that really focus our attention on if we're going to be measuring change strategies, what should we be looking at in terms of how we decide whether or not those strategies were effective? Next slide. So for those of you who don't know, there was actually an anthropologist, Everett Rogers, who talks about 5 points of innovations. And he basically makes the case that if you're going to change a practice, then you have to consider 5 areas at a minimum, but these are the most 5 critical areas in order to really make a determination that it's worth making that change and that you can actually sustain that change. And those 5 areas are whether or not the new innovation has a relative advantage over existing practice, whether or not the new innovation fits within your current culture and programming, whether or not the new innovation is simple. Complexity actually makes things really hard. And of course, when we're doing cross-agency works, that's very complex work. But in fact, if you can break it down, you can get to those simple pieces. Trialability has to do with, can you basically try something out, pilot it to see whether or not it actually has some alignment to your current mission and your goals. And then observability, and that's basically where people who work in the setting can feel the change, can feel the importance of that change, and actually can make a judgment that it was worthwhile. Now, I raise these 5 points because in implementation science, these are actually outcome measures that we could be looking at as a way of really helping our systems understand why some of the innovations that you're currently involved in make sense. Next slide. So my colleague, Steve Belinko, who's at Temple University, and myself wrote a book called Implementation of Evidence-Based Community Corrections and Addiction Treatment. And it's basically a way of applying the principles of evidence-based practices and implementation science to the field of community corrections, prisons, jails, essentially this cross-system work that we all are engaged in. So cross-system work is difficult work because we have layers of organizations that are involved in those activities. And we have to think about how to collectively grow so that we develop a knowledge about what are the problems and why is this particular solution make sense for this environment, to build a foundation that really helps us develop the skills of the staff and the stakeholders in terms of really putting the initiative in place, setting clear expectations about what's likely to occur, aligning the initiative to the different cultures and environment, renovating those initiatives, and then really embedding them into the daily process and work. So this interagency evidence-based implementation framework basically says there are phases, just like the stages of change that clients go through, but there are phases in which you can work on your grant or you can work on your new initiative. And those phases are basically around making sure that the environment is prepared and that the staff and clients actually have an understanding of why this new way of doing business makes sense. There's a lot in this particular graph and this model. I'm happy to share information with you, and CSG actually has on their website a manual that we wrote that describes in more detail the steps that are really put in place. But the implementation guidelines that Sarah is going to talk about in a few minutes mirror these particular ribbons that are part of the effort of really having teams work closely together to put in place in a solid fashion the implementation of your grant or your new initiative. So you can stay tuned to hear about some of those guidelines. Next slide. So as I said, one thing that's really important in the process of implementation is managing expectations. So I always like to tell the story that in 2008, when the Second Chance Act was passed by Congress, Congress actually had an expectation that the Second Chance Act would reduce recidivism rate by 50%. So everyone can laugh because we all know that that's an unrealistic expectation. First of all, when research came out and the average grantee was spending an additional $800 for each client that was coming back from prison, would we expect a 50% reduction in recidivism? I think Lisa and Laura will basically say, well, not really, even in the best of scenarios. And this is one of the things that the implementation process needs to work through is what are the expectations of staff in your agencies, and what are the expectations of all the other organizations that basically are looking at this initiative as a change process. So that could be judges, it could be a local sheriff, it could be the police department, it could be your county commissioners, treatment providers. Everybody has expectations, and we really need to spend time talking about those, because the first thing that can happen with new initiatives is people say, oh, it didn't work. You know, they kind of go through the relative advantage. Nope. Feasible. Nope. Observable. Nope. Not going to work. And that's because of these high expectations that are unlikely to actually occur in very short periods of time. And as we all know, grants are very short periods of time. So this is an important area in terms of talking about your goals, but then also what do people want to see? And that's part of the change process that needs to be dealt with. Next slide. So this particular slide, and I'm using as an example here, medications for people with opioid use disorders, but you could put in here any type of innovation. So one needs to actually, in implementation science, look at the inner settings. That's the organization that is responsible for implementing the change. And then the external, which are the collaborating partners. And you could look at both what happens inside and outside to really examine where are you going to have your barriers from and where are you going to have your facilitators. Now, this type of analysis is very important in the implementation process because it helps to align the goals and expectations. It also gets out on the table some of those bugaboos that exist that are the barriers to change. As a good friend of mine, Glenn Tapia, always says, culture is king. Culture will eat you for breakfast, lunch, dinner, dessert, every appetizer you might have. And so you have to understand how these cultures can be shifted to support new innovations. And the reason I use medications for opioid use disorders as an example is that, it's really the integration of medical care for people with addiction disorders. And we have a lot of beliefs that people shouldn't have medication because it's just substituting one drug for another. Two, medications, are basically not effective. It doesn't really, help people with their addiction use disorders, and so forth. And in the criminal legal system, of course, there are lots of misinterpretations about what medications are and how they can be effectively used. And so you're going to hear from both Lisa and Laura about some of the ways that they have worked within their existing environments to be able to build knowledge and build the skills and build the confidence within their own agency settings, but also across the county government and Fairfax County, Virginia. Next slide. So, as I said, implementation science gives us a new way of thinking about what it is we're doing. So, grants are new ideas, innovations, evidence-based practices. Those are what we're planning to do. But then we have to think about how do we put those in place? What are some of the different strategies that we could use? And there's a ton of different strategies. In fact, Eric Powell has documented 78 different strategies, if you're interested. But today we're going to talk about quality improvement process as one strategy, and policy teams as another strategy. But there are also different implementation outcomes. I spoke about Everett Rogers. He gave us some ideas about implementation outcomes, which are at the agency level or at the county level. Then we have program outcomes, and then we get to individual level outcomes. So what I like about implementation science is we're not basically looking for miracles at the individual level, changing that recidivism rate, helping people improve their health outcomes, until we're sure that we've implemented something. And of course, in science, what we've learned quite a bit is that implementation is hard to do, which is why a focus on implementation science could be very valuable for us. So, this is to give you some ideas for those of you who are the researchers on your team of different outcomes. And I really recommend that you look at these implementation outcomes. And again, CSG has a manual that can really help us look at some of those outcomes. Next slide. So we're going to turn our attention now to something called Quality Improvement Process, or PDSA, Plan, Do, Study, Act. What's nice about the Plan, Do, Study, Act is that it's a team-built process. It's designed at the micro level to be able to deal with initiatives. It involves data, and so it's data-driven, and it really focuses our attention on a problem and testing out ideas. So unlike your typical evaluation, which I love to do, that usually take 5 years, the PDSA process is really a rapid cycle process to get information. It helps to deal with some of those issues related to expectations. So you can basically pilot something, see how it's going, and feel like you're making improvements or encountering new barriers that you're going to have to work through. Next slide. So what we want to do now is share with you a video of an implementation science process called NIATEX, which is basically comes from the network to improve addiction treatment programs. I also want to call your attention to a website for the project called JCoin. The JTech website has a number of free courses and other resources that can help your organization. And so you should feel free to dive in there. But if we could put on this video for a few seconds, just so we could see what NIATEX and quality improvement is.
At NIATEX, one of the main things we do is to teach process improvement to behavioral health and human service professionals. Now, we've been known to explain our entire model of process improvement to folks over lunch. It's that simple. Here's how it works. Whenever you want to make a change or improve something in your organization, you start a change project. Now, every change project has one aim. Think of the aim as the target. It's that specific, measurable goal you're trying to achieve. Now, to carry out a change project, you need people and some tools. On the people side, we emphasize 3 key roles. The executive sponsor, they're often a senior leader in the organization, and they help remove barriers for the project. The change leader is the project owner, and they lead and coordinate the change team, which is a group of staff members selected to work on the change project. Now, when it comes to process improvement tools, the NIATEX model focuses on 4 that we've found to be easy to learn and effective for most change projects. The walkthrough is a tool to help you experience a process just as your customer would. Flowcharting creates an actual picture of the process from beginning to end. The nominal group technique, this is a tool the change team uses to brainstorm ideas that will help achieve the aim of the change project. And the PDSA, which is an acronym for Plan, Do, Study, Act, is an efficient way to test changes. Rapid cycle testing, that simply allows the change team to try a change for a short period of time to see if it's an improvement. Finally, the NIATEX model has 3 rules for change leaders and their teams to follow when conducting a change project. 1 is to use existing resources. The goal is to achieve your change project aim using currently available staff and materials. 2 is to measure change. Simple measures are the lifeblood of successful change projects. So collect only the information you need to achieve your project aim. And 3 is to sustain the gains. Now, once you've achieved your aim and the change project ends, you must have a plan in place to monitor your measures and intervene if they creep back to unacceptable levels. That's it, the entire NIATEX model of process improvement. Now, to gain a deeper understanding of process improvement and the NIATEX approach, view our online course, Process Improvement 101, at niatex.net.
Thank you.
At NIATEX, one of the main
Thank you very much. So as you can see, the concept of NIATEX quality improvement is pretty simple, but when you get into it, it actually has a lot of key components. So we're going to do a very quick drive-by to follow on to that video of what those components are. And, again, you have the niatex.net, which has a course on that particular process. The JTech website also of JCoin actually has more details regarding that particular process. And it has a number of other important curriculum that are designed to really help people understand how to make change. Like we have a curriculum on justice cultures and understanding justice cultures. Then we have a curriculum having to do with how to do focus groups and mixed methods and things like that. Okay, so PDSA, Plan, Do, Study, Act. There's essentially 4 parts. There's a little bit of the beginning part, which is setting the stage. And then you have 3 parts within the PDSA planning part, which is brainstorm ideas, figure out what your problems are, create solutions, and then from those solutions, decide what it is you're going to put in place. And so let's walk through this. Next slide. Okay, so one thing important, who's at the table? We always recommend that you have 3 types of people at the table. And this is internal to your organization, but for interagencies and system buildings, I would also highly recommend you have 3 types of people from your external partners. The 3 types should be everybody's, high performers, the kind of middle folks who are consensus builders, and then a must-do, you have to have a naysayer. Why do you need a naysayer? Because the science around organizational change has found that involving naysayers in the process can convert people to become the champions of change. And you will be surprised how people who initially were like, no way, we're not going to do this. This is not fitting, they can turn into the biggest supporters for the change. So that's why it's important to have this vertical slice involved in your quality improvement process. Next slide. The other part is you got to think about who in your staff. So you don't want the agency favorites. You really run a cross section of different levels. Again, because part of the change process and policy team process is to convert people to understand the issues deeper, but also participate in coming up with some of the solutions. And, essentially people on the front line have a lot of information that's oftentimes untapped. Next slide. So the planning process basically involves a number of different pieces, as I said before. You need to select a big problem, narrow the problem, confirm that that's really the problem, because sometimes you think something's a problem, but actually it's something else. Brainstorm solutions, come up with ideas, identify the steps that you would need to take to put something in place, and identify what resources you need, and then begin to delegate and clarify roles in the change process. Walking through these 8 steps is a way of getting buy-in And it's also a way of helping people understand, which is part of, the interagency, understand the problem at a deeper level, but then also understand what it takes to resolve that problem. Next slide. So I'm going to share with you something called the cascade of care. This is an example from my colleague, Steve Belinko and others, who basically look at this question about cross-system issues. So we know in the field of the criminal legal system that that one of the largest issues we face is referring people to appropriate services. And what this model does is it basically helps us visualize how well the system and agencies are functioning in that referral process. So you could see here in this example from the juvenile justice system that, at the front end, we miss a lot of opportunities to screen people for a particular substance use, mental health, or behavioral health need, or even chronic illness. We lose opportunities because after screening, we do very little assessment. And we then have a number of people who could be identified in need. But then the question really is are we providing appropriate care for those individuals? And you could see here how referral rates and then initiation for treatment really are affected by the front end, which is the screening. Now, what's nice here about this cascade of care is it really shows that when you have an interagency effort, this could actually be exasperated, that there's very little that can actually be done. That very few people walk through the different phases. I should say, though, oftentimes in agencies, like when you have a prison and you also have people transition from prison to probation or parole, oftentimes information doesn't go with that person. And so the referral process gets shortchanged again. So the cascade of care is really a tool that you can use to look at your problems and begin to think about what type of solutions and where should we offer these solutions. Next slide. So once you figure out where the problems or bottlenecks are, you come up with your grand ideas or you've got a grant to be able to address it, then you just have to do the hard work of putting it in place. And, as we all know, it's a lot of work and it involves a lot of teamwork. So the preparation work that you've done in the planning can carry you through the do stage in terms of really trying to fine tune how to put that idea into place. Next slide. So, not just because I'm a researcher, but, also if you work in an agency, collecting data about your process, like that cascade for care model, you can collect that at baseline and then collect it after you've implemented your change to see what kind of movement there is. And that's really what you want to be able to convey to others, that, there is a benefit that comes from these particular changes that you're putting in place. Next slide. Okay. So then the final piece is assessment. Now, not all of our good ideas translate into things that are workable. Sometimes we have to pivot and we have to adapt it. Sometimes we have to say, that was a nice idea, but it didn't really work the way we wanted it to. And then you begin to think about how you're going to reframe it. So in the ACT stage of PDSA, it's really a time to really assess, should we move forward? How do we sustain this effort? Or, did it meet the goals that we expected it to? Next stage, there's a slide. Okay, so I wanted to just share with you, we've used this PDSA in many criminal legal system environments. One of my former students, Shannon Magnuson, who's now with Justice Systems Partners, she spearheaded a study where we looked at the questions about whether or not probation officers thought about the PDSA process. And you could see here that there was a lot of support for officers being involved in being able to correct some of the issues that occur. So there was a lot of support for officers who believe the PDSA, gives them a voice in fixing local problems, that what actually was put in place fit how they think should be done. You could see there's even more support for that. And there's even greater support in terms of people thinking that they were part of the solution and not just naysayers. So that's one, example. There's lots of other examples of where these quality improvement processes have helped organizations to deal with that sticky issue of culture. Next slide. And these are just some quotes that of some of these officers who participated in the PDSA process. I should say that what's nice about the PDSA process is that lots of organizations have policy teams. And what PDSA does is give a structure for how those policy teams can work together and can grow, as well as serve as one of the problem solvers for their particular organization. I remember a couple of years ago, I was talking with Lisa and Laura, and they were talking about some of the diversion first work that they were doing in Fairfax County. And I believe it was Lisa, but it could be Laura, not sure, was talking about how in your process to implement diversion first, you had a mid-level manager group who was really responsible at trying to problem solve some of the sticky parts that occur in the implementation process. And personally, I was like, wow, that is really a cool idea, one. But two, it really fits within PDSA in the sense that in the study part, we notice the barriers to implementation, and those barriers are things that we really have to pay attention to. And so putting away a process to do that can be very powerful. So I'm now going to turn the presentation over to Sarah, who's going to talk about the implementation guidelines that CSG and myself developed. Thank you.
Thanks so much, Faye. Yeah, so really what started this was in working with the Justice and Mental Health Collaboration Program grantees. You can go to the next slide. I just sent a link to this website too. We found that, a lot of folks as a part of this are trying to implement evidence-based practices, including just screening and assessment with fidelity, as well as different interventions to address people with mental illness and co-occurring substance use disorders in the justice system. So we were trying to think how to break it down to make it easier for people to have a quick reference guide to try to see if they were following implementation science best practices. Next slide. So what we did is we tried to break this down into 8 different steps. And so it's possible one could go through this step by step, but a lot of this is cyclical. So you may start step 4 and then find out you're back at step 1 trying to get new stakeholders due to turnover, different political leadership changes, and things like that. So really you can look at it as a step-by-step, but just also as general concepts for each of them, and then you can come back to them at any time. So the steps kind of highlight different areas you'd need to think through for going through and implementing evidence-based practices and following implementation sciences. So in the first step, it really talks about stakeholders. So do you have the right leadership buy-in? So thinking about that NIATEX video that we saw, do you have the right stakeholders? Is the right change agents at the table to be able to implement this? The next one is on identifying a problem and selecting an evidence-based practice. So you could have a specific issue with people who have unstable housing. So then you would look at, how do I screen for that? And is there an intervention that could address that? So really getting to the core of what's the target population, and then how do you select an intervention or evidence-based practice that would support that? The step 3 is really preparing for implementation. So what are the things that you need to do before you implement? So really getting more of the information on how to move towards implementing a program. Step 4 is measuring fidelity. So this is a big one. So like what processes did you set up to measure if your evidence-based practice is actually having fidelity to the model? So in some cases, it might be manualized treatment program, and there might be really specific ways of tracking fidelity. And in other cases, you may have to actually develop this as a group using your own data to really think through what are the check marks you want to have in place to make sure your staff has the support for coaching and implementing. Step 5 is a huge one, and this is one that we will discuss with Lisa and Laura and Faye later: sustaining evidence-based practices. So these take a long time to implement. It can take, 5 years to really have true implementation of evidence-based practices. And then with staff turnover, you may have to retrain people. So how do you sustain these EBPs over the long term and have the funding to continue to be able to implement them? The next step is around mastering core competencies. So this is around the state training and coaching of staff. So how do you keep up the skills to be able to do evidence-based practices as part of your organization? Step 7 is on implementing quality improvement processes. So some of the PDSA stuff we discussed could fall under this piece, and we'll actually jump into this more as well a little bit later through our discussion. And then step 8, last but really not least at all, is assessing your organizational readiness for managing EBPs. So how do you know that you have the right things in a job description so people know what they're going to do for this? How do you know that your organization is ready to take on this type of change process? Because often it is changing the business as usual to implement an evidence-based practice. And then also on the site, we have additional research and supporting information. So this is kind of the foundation for the discussion. We'll come back and dive in a little bit more after we hear from the Fairfax County folks. Next slide, please. So I'm gonna pass it to Lisa and Laura to talk a little bit about implementation of medication-assisted treatment in Fairfax.
Hi, thank you so much, Sarah and Dr. Taxman. Good afternoon, everyone. I'm Lisa Potter, and Laura Yeager and I are going to talk a bit about our local efforts. And I'll start out by providing some context about our approach to step 1, or stakeholder collaboration. And I'm going to focus on the front end, and then Laura will focus more on the program implementation piece of things. So just to take a quick step back on where we started and how we got to step 1, in 2015, a small but very influential group of county leaders came together with a vision to address gaps in the intersection between the justice system, criminal justice system, and behavioral health, and transform our local system. The group included our sheriff, who you'll hear more about a little bit later, our deputy county executives, the executive director of our behavioral health system, our police chief, and chairman of our board of supervisors, as well as a board member. So this vision that they came up with became Diversion First, which is our countywide initiative to offer alternatives to arrest and incarceration for people with mental illness, substance use disorders, or developmental disabilities who come into contact with the criminal justice system for low-level offenses. The goal is to intervene wherever possible and provide assessment, treatment, needed support, and prevent repeated encounters with the criminal justice system. I should also mention that there were efforts to establish diversion services in our locality in the early 2000s, but there really wasn't tremendous wide-scale support or resource commitments at that time. And after some tragic community events, including the death of a woman with mental illness who was incarcerated, and following an ad hoc police practices review commission, county leaders united to build a countywide system for diversion. So in looking at step one in the checklist, an interagency leadership group was convened and included leadership from agencies that would be part of Diversion First. So that included Health and Human Services, Public Safety, courts, and the group really focused on setting policy, addressing barriers and challenges, committing to resources, and it also provided an opportunity for relationship building for groups of people that were historically really non-traditional partners. So in addition to that, a community stakeholders group was convened to identify community needs and also provide input on reimagining what services could look like. And I'll mention that as Diversion First has evolved, this group has also been instrumental in helping with advocacy efforts along the way. So related to Diversion First, with additional focus on the opioid crisis, an opioid and substance use task force was convened in 2017 with the goals of reducing opioid-related death, improving quality of life for individuals and families impacted by opioid use, and to use data to inform strategies, interventions, and to evaluate program effectiveness. So for both initiatives, it's been really helpful and important to have an established group that has common goals, that addresses policy issues and barriers, and it really allows for system readiness to act quickly and seize opportunities, as well as to grow and sustain the initiative. So this is the group that really helps to guide the overall initiatives. Champions and influential stakeholders definitely set the pace for system transformation and lead culture change. Dr. Taxman mentioned how critical culture is, and that's certainly been huge in everything that we've done. So champions communicate a vision, the values, goals, set policy to achieve goals, and ensure that processes, roles, and practices change to support the work. So as an example, when we established our Merrifield Crisis Response Center, which is a CIT assessment site, we have law enforcement officers working side by side with behavioral health clinicians for the first time. And each agency, there are 3 agencies involved, have their own organizational culture, policies, legal parameters, and chain of command. So it was really critical for leaders of these organizations to set the expectations, to address any challenges, to really support and empower this cross-system team. And trust really evolves over time. Communication is so key, and staff need to really be empowered to be part of the solution and to take some risks. Dr. Taxman also mentioned that we have implementation teams that include really staff at all levels. And I think what Dr. Taxman said about having the naysayers in the room is critical to any system change. You have to have people to push back, to challenge, and then they really become, hopefully over time, part of the leaders for culture change. But they also want you to recognize things that you might not have noticed without them in the room. If you have a bunch of cheerleaders in the room, that's always great, but it's always helpful to have someone say, I'm not sure about that, and how would it work logistically? So while we had the overarching structure, we had all of these different work groups that stayed informed of evidence-based practice, that looked for programs really all across the country that could help and serve as a guide for successful implementation. Dedicated project coordinator, that's really my role. And I should mention that Lori Yeager was in my role before I was in this role. So this is near and dear to both of us. Really, all of the services under the Diversion First umbrella involve multiple agencies. No one agency owns it. although many of them may say that I own it, and that's great. We want everyone to own it. So it really is a huge collaborative effort. And from the beginning, our leadership recognized the importance of having a dedicated position and someone to act as an honest broker to help coordinate activities and move them forward. So a lot of the role is bringing groups together, helping to establish multidisciplinary services, brokering service system agreements, solving problems, securing resources, establishing relationships, and involved in some operations, but also focused on the big picture. In terms of action steps, accountability is key and can be accomplished in a variety of different ways. Project management or action plans with timelines, and frequent communication with internal and external stakeholders early on to create momentum, and in later stages so the priorities don't shift. Certainly assess on an ongoing basis, both implementation outcomes, program outcomes, and individual outcomes, as Dr. Taxman mentioned earlier, and review data and look for quality improvement opportunities. Also to seek input from stakeholders, including those who have used the service or a similar service or will use the service in the future. So next slide, please. Our implementation framework from the beginning was to use the sequential intercept model to guide all of our efforts with the intention of building capacity at each of the intercept points. And to determine how to build services, we assess needs to include stakeholder input, review data such as number of people in jail with behavioral health issues, number of days in jail, calls for service involving behavioral health. We identify gaps such as the need for outreach to frequent utilizers of public safety services, free trial services tailored to this population, and quality improvement activities. When people are falling through the cracks after they're diverted, how do we re-engage them in services? So really all of these were examples of PDSA strategies that we used. We tried something out. We love a pilot. We reviewed data, we modified as we went. And once you can demonstrate outcomes, you're really in a great position to advocate for resources. Our goal was to develop a continuum of services with evidence-based practices and best practices embedded throughout, such as assertive community treatment, CBT, peer recovery supports, validated screening tools, contingency management, toxicology screening. They're evidence-based practices threaded throughout. And based on identified needs, gaps, data reviewed, jail-based services and medication-assisted treatment at intercepts 3, 4, and 5 were identified as priority services in our county and within our jail. So I'm going to turn it over to Laura Yeager, who will provide details about medication-assisted treatment and program implementation.
Thanks, Lisa, and it's fun to get the team back together again. Next slide, please. So a little bit about our program. This is a picture of our sheriff, Stacy Kincaid. And if you were to talk to her, if she were presenting, she would tell you that she was not really supportive of medication for opioid use disorder in her jail when we proposed this, and had a lot of different ideas. And this is about readiness, but as she learned more and started to look at the evidence and the research and the data, she became convinced that this was our jail's #1 response to combating the opioid crisis and reducing overdose deaths in our community. So we're a little bit unusual in that we started this in 2000. We really looked at, this isn't just sort of a special thing that goes over there to the behavioral health people. Our sheriff's office really owned this process. And we look at opioid use disorder as a chronic illness, and that jails are mandated by the Supreme Court to treat chronic illness in jails. That's a huge culture change to begin to look in public safety and have people start to think about addiction as a chronic illness. So we've had a huge culture change. We've had a lot of education with among our staff, both medical and confinement. So I'm going to go through this quickly, but we started looking at evidence-based approaches at the time someone came in. If Dr. Taxman was going to talk about evaluation, she'd say, start with the end in mind. So we started with where do we need to go? And we need to figure out who comes through our doors who have opioid use disorder. So we started discovering evidence-based ways to do that, and to begin to provide a comfortable withdrawal process, but also look at treatment. And as everyone's talked about, you don't do anything in a vacuum. There's been a ton of collaboration to make it happen. We'll talk more about sustainability, but one of the things we did from the beginning is start to change our standard operating procedures to be inclusive of MAT protocols, to be inclusive of treating opioid use disorder. And they're sprinkled throughout all our confinement and medical standard operating procedures. We also know that and I'll talk more about the implementation, it's complicated to implement this in jail, but by doing it in jail, if we don't focus on what happens when someone leaves jail, we're just gonna see them back through here, where we need to look sort of downstream and upstream and make sure we're putting supports into place to I like to say we try to give people enough support to never see them again through our doors. That's my hope. And we know that treatment works and recovery is possible. That is not necessarily the typical thing you'll hear a sheriff talk about around the country, but there's been a real sea change here. Next slide. We also had to get through a lot of myth busters that treating someone for opioid use disorder costs so much. And we learned through a lot of research and studies that it is sort of not that expensive. I would call it, when I compare our costs for HIV or AIDS medication or for heart disease, this is not the most expensive thing we're spending our money on, but we had to get people wrapped around thinking that way. We also had to focus our staff on recovery, that there's a lot of evidence that says we can treat opioid use disorder and we can have great outcomes just like other chronic diseases. People, the idea of replacing one drug with the other, we know that that's not accurate, but getting people to start thinking about drug abuse and medication as sort of two different things. And also our philosophy that just withdrawing someone comfortably from opioid use is not good enough for us. We have an opportunity when someone is confined to actually treat their illness. And we know that we need to treat them for 1 to 3 years, and they're not going to necessarily be in our custody during that time. So we're just starting them. Next slide. Just some examples of, because we've been talking about all these evidence-based practices. Some of this follows what you heard before, but we really had to figure out what works. So we know that if someone is booked into jail, it doesn't mean we look at them and go, well, there's someone who has opioid use disorder. We really had to adopt validated screening tools, which we did. We had to change the way we look at people at intake. And as a result of that, when we started doing MAT, we had just under 2% of our population that screened positive. Now, like today, I'll just give you an idea of how we have about 600 people in the jail. And today the report came out, I think we're treating 67 people. So we track this data. We know how many people we're treating. It's a complicated process. So we added these tools. You can look them up online as part of our screening. We also added urinalysis and pregnancy testing. If you go to any doctor's office, they're going to do that. We didn't have that as a common practice. So these are just simple little things that we added in that made sense when we're trying to determine who gets treatment. Next slide, please. The other thing we really focused on, you know, our medical staff are doing this treatment. And we really had to get to moving away from being subjective and bringing in more science, which is where we talk about evidence-based practices. And just sort of a little example of a quality cycle that Faye talked about. We use this clinical opioid withdrawal scale. It's an evidence-based practice, but if you don't do it right, you don't get good information. So we had nurses doing this withdrawal protocol, and there's a sort of subjective scoring process. We had someone who adapted the scale, so you didn't even have a score that was telling you anything. But we did intensive training with staff. We started to help people understand what we were trying to measure. And then we embedded it in our electronic health record so that it's self-scored. So a nurse didn't have to add everything up and have that spot. I hope these are just simple examples of how we approach this. Next slide, please. We also incorporated peer support services, and I think many people are aware of peer support services. Also, an evidence-based practice. We know that when we use people, or we have employees who have lived experience, who have been in jail, who have experienced addiction issues, they play a really vital role to engaging people, to relating people that a nurse or a clinician or a prescriber may not be able to do. They can help motivate people to focus on a life in recovery. That created some interesting security background checks. You know, we're a jail and we like to be secure, and we don't like to let certain people into our jail, or we don't like to employ certain people if they have criminal backgrounds. So this resulted in a lot of change just to get people into jail. We've been highly successful in it, and part of that is working with our confinement staff and having them really understand what we're trying to do. Our peer staff do a lot of inreach into the jail to motivate people. They provide peer support groups and bring AA and NA meetings on site. And we also, the future focus of what happens when you leave the jail. Next slide, please. The other thing that is, as we learned, became very important to us is if we treat someone and we don't send them out with a plan, or we don't help them link to the community, they're not going to do well. So as much as time as we've spent developing a MAT program in the jail, when we release people, it's just as important. So, and some of this we've learned by trial and error, by piloting many approaches. We provide people with prescriptions when they leave and bridge doses until they have an appointment in an outpatient clinic. We Uber people. We have an Uber account at our jail where we will send people directly to the outpatient clinic. Everyone leaves with Narcan. And we, you know, most in the old world of treatment programs or jails, harm reduction, we don't have any room for harm reduction, but we know that not everyone is going to stick with the program or have a smooth path, even with all the supports we put into place. So we provide everyone with Narcan. Next slide, please. So going back to sort of this quality cycle, at the beginning, when we're screening people for opioid use, we also start planning for their release, because we need people to link with community-based treatment. And most jails, or the old way of thinking is, when you have completed your time with us, you're free to go, and you still are free to go. But now we try to send you out with supports that are going to help you be successful in the community, to not see you again. So we have people, we set up an outpatient clinic appointment with them prior to release. We're getting ready to make a home movie that shows what that clinic looks like, what to expect when you walk through the door. If any of you have ever gone to a new doctor where you're going to have to get examined, you know, it's sort of scary. You want to go early. You don't know the paperwork you have to fill out. You don't know what to expect. And you certainly don't want to take your clothes off in front of a stranger. I don't know. It's just that's not an evidence-based approach, but that's a fact. So we try to prepare people for going to the clinic. We provide recovery housing scholarships. We want people to go to, and we have a small grant to do this. We try to enroll people in Medicaid because they might not be focused on healthcare, but we are prior to their release. And we also are starting a phone program where we release people with a cell phone and a month of unlimited service. It's super inexpensive. If they go to the outpatient clinic, they will get a card with another 1 month of service. And we're finding that this is another way to help connect people. But the key two things are, we try to do MAT in the jail properly with induction and treat people, but then we try to get them released with supports wrapped around them. Next slide.
Thank you so much. So now we're going to actually talk through a couple of different areas related to this. And if any of you have questions who are listening, please feel free to also drop your questions in the chat and we'll definitely be covering those too. So if you can go to the next slide. So we picked two different areas that we think are specifically tricky just based upon our experience working with sites around the country. And the first one is around sustaining evidence-based practice. So for reference, in this checklist, we talk about monitoring implementation benchmarks for the evidence-based practice, identifying features that produce positive outcomes and areas for improvement, identifying resources needed to fully implement, revisiting the logic model. So as you continue, things change and you need to keep your documents updated so your process is up to date in case there's any changes in staffing, refining the process for implementing the evidence-based practice, and then reassessing the process and the performance measures and really relooking at outputs and outcomes. So this is an area that can be particularly tricky as funding sources come and go. So maybe you have a federal grant and then it leaves and you have to figure out how to sustain it. Next slide, please. So I wanted to ask our panelist a little bit about this step specifically. And has the evidence-based practice, or we're calling it EBP here, been performing as expected in the past year? So I think Laura, I'll ask you that one first, if that works.
No, they are not always performing as expected, to be perfectly honest. On paper, everything looks very good, very linear and very perfect. But in reality, when we're dealing with humans and we're dealing with errors and that kind of thing, no. So I'll give you an example. We have, the medications that we use have a high value in the jail, and they've created their own little economy if medications are diverted. So we started out using the medication, it's buprenorphine we use, and they come in little tabs dissolved under the tongue. So if you don't do a medication check regularly, if you're not checking, if you're not using a flashlight, it's very easy to divert medication. So we caught on very quickly, or when people see a pill, they think they swallow it. So we have to administer the medication properly. And we learned that a whole tab, we were creating a lot of opportunity for diversion. So one of our staff had a great idea. They have this medication in a film form that dissolves under the tongue. And we're like, that's the answer, the film form. We were like so happy. We did the film form, but we discovered that's really easy for someone to stick up behind their teeth, to take a cup and put it in a cup, to cheek it. Even with med checks, a clear strip is easy to divert. And we had strips showing up and people selling strips. So we did a lot of research. We talked to a lot of other jails in the country who are doing this, and they said, we crushed the meds. We got permission to do that. So now we have a different medication process. We discovered still medication was getting diverted. So now we're shaking it up. So we're doing little pilots to try to figure out the best way to do it. Now we're having med lines with the deputy observing and a nurse administering meds. We have a protocol in place where people have to keep their hands down, and it's going much smoother. But I know the minute we have that sort of set in place is the minute we're going to have to, I think we use the word pivot. We pivot daily. So we have to pivot again. But the great thing about this is our staff have become very engaged in the process, and they're kind of becoming little scientists. Like, let's try this approach and see if it works. So I think when people get engaged in trying to problem solve and trying to work out these adjustments, you get a better product. So it's been exciting and horrible at the same time, because things don't go as planned, but we adjust along the way when we discover they're not working. I hope that helped.
Definitely. And I think that's really important as you're implementing these, is that you have to make adaptations and you have to continue to do that as the process moves forward. And the context in your jail changes regularly, and who's in the jail changes. So you've got to adapt based on that. So I'm curious if a process or outcome study has been conducted at all in Fairfax County at this time? And if not, has that been something that you've considered?
Yes, so we started, and when we look at process measures, we try to figure out what do we collect that we can actually put into a report format? What are the, we try to figure out what's the stuff we already know. So we've tracked sort of as we've become more sophisticated in what we're doing, how much participation has increased and how much how many people we're screening in as positive. So that we definitely have seen a total from 2%. Now we're averaging 10 to 13%, and we measure that monthly. It's easy to do. We are definitely measuring incident reports. So we track med errors, typical things that jails do, but we now tie it into this. And we also track the people who leave the jail and how they make that connection into the community. So we definitely, we track how many people were screened for opioid use disorder, how many were booked, how many were referred for treatment, how many are in treatment, and that kind of thing. And those are really easy measures, but they tell a story. And when we can illustrate it either with a graph or we can show staff, look how we've changed. Why do you think why these numbers are different? Do we have more people in jail? We don't, but we've gotten better at what we do. So it's been exciting in that regard, and people are using data and asking questions about maybe we could measure this. So that's when I know we're doing something right.
Faye, I'm curious from your perspective as a researcher, when is a good time to consider a process or outcome study?
Well, so I spoke about implementation science, and implementation science is actually different than process evaluations. So implementation science really does some of the things that Laura was alluding to in terms of trying to really measure where's the staff in the organization on this innovation. So my suggestion would be that, and there's some pretty easy tools available now that are in the public domain to measure implementation outcomes. Yeah, they're in that checklist, right? And I would highly recommend that, within the first 6 months, you start measuring implementation outcomes. And then you could use those as data points, as Laura suggested, to really then figure out what do you need to do to garner more support from the institution. So I think in Laura, in discussing some of the challenges they have with drug diversion in jail settings with medications, the storyline that you didn't really, that wasn't emphasized enough was this whole question about the staff now understand this is part of the process, right? That, you're going to have to pivot, change how we distribute the medications, and that's okay. And that's not a sign of failure. That's a pretty high performing organization. So kudos to Laura and Lisa for their efforts. But I would say, if you can begin to measure some of the implementation outcomes, you can begin to use that to really modify the culture. I recommend an outcome study, to be perfectly honest, 5 years after you've put in place and worked out all the bugs. We have a ton of research studies that basically say no effects, right? Didn't make a difference. But really, in most of those studies, if you peel them back, it's because nothing was really implemented. They were done during a pretty early period of time. So, in my book, I would never do an outcome study. I know everybody wants one, but until the program has matured, I'd invest more in some of the qualitative measures about how's this working in your environment. So Sarah, there is from Rhonda Frank Lauren a question for Laura or Lisa regarding explaining the Medicaid enrollment 40 days prior to release. What did it take to get you to put that in place?
I can jump on that. So in Virginia, we are a state late to the table at expansion. And, you know, so when someone comes to jail, they're medicated. If they're on Medicaid, it's suspended, or maybe they just aren't even interested or haven't been involved in healthcare, because we have a lot of people here in compromised health. In Virginia, the regulation is if you have a release date and you know you can start to apply 45 days. I personally wish it was much more accessible, but in Virginia, there's an 800 number to the DMAS office to register and see if you're eligible for Medicaid. It's a little clunky because if I was not, like, let's say I'm an inmate in the jail, I have to get to the phone, I have to find that number, and then I have to have someone like a deputy verify that I am who I say I am. And then sometimes it can be up to 45 minutes going through this interview process. But our hope is that everyone can walk out of here with healthcare and walk out of here with benefits to help pay for their medication when they leave. So in Virginia, it's an 800 number. When you're incarcerated, it takes a lot of time, and it's a bit of a, these are, in my opinion, some of the most people at most risk for chronic health issues and overdose deaths. So it should be easier than that, I believe, but there are a lot of people paying attention to this issue. So that's, to make it happen, it's having, we have a couple of reentry staff, which is our sheriff created. Some of them, part of their job is looking to the future, and they help folks sign up for Medicaid. I hope that answered your question. It really relates to what your state Medicaid regs are.
Yeah, that's what I was going to say. So in each state, the way that Medicaid agencies deal with incarceration would either be through suspension or termination, and the policies would vary depending on your state. There are also states who have Medicaid waivers that are focused around additional service delivery for the justice system. So there are some states who serve as examples for a better way to coordinate care as people re-enter the community. So some of it is state dependent in terms of how they would suspend or terminate coverage during an incarceration stay. So if you're not sure what that looks like for your state, would encourage you to look at your state Medicaid and Medicare Services Agency website. Also, I think there's a good resource that I can put on the chat where it talks about each state's policies on that too. So would encourage you to look at your state specific regulations on that piece. We have another question, and it says that my agency, and this is a specific question to some of the things regarding jail and reentry. So it says my agency had issues with providing backpack types to people exiting with resource guides, prescriptions, other things. It was seen as a liability for people exiting and could harm themselves by taking the backpack apart, like their drawstrings and stuff like that. They're asking for what is the opinion on this and how would we suggest to resolve that?
I can talk to that a little bit. Everybody is very risk averse, and I think I speak for anyone who's worked in a jail. Jails are very, we're all risk averse. Nobody wants there to be a problem. We want people to stay alive while they're in our custody and after they leave. In our jail, we do have a backpack program, and very similar to what you're providing. They don't get the backpack when they're in jail, so they have no opportunity to use the string to harm themselves. And most people, how destigmatizing it is to be able to walk out of the jail with a backpack instead of a clear garbage bag with your possessions that you then, some people carry it through the campus here. I mean, if we're trying to really look at stigma and look at treating people normally, we have Narcan in it, we have fentanyl test strips that we provide, we have resources, phones, but we hand it to them when they leave, sort of like your fabulous parting gift. We're not worried about the risk of self-harm. I'm not sure. I think if you whoever is concerned about that being a tool of self-harm, I think that might be a stretch. And while we try to keep people safe when they're in our custody, when they leave our custody, having a drawstring on a backpack removed is not the greatest risk people are facing, I guess is how I'd put it. That's my opinion. So I'm not, but do other people have ideas, or throw it in the chat, I guess, if other people are doing this.
I think it's good to look to other agencies like Laura is suggesting that have been able to do this and think about, how it was able to be implemented in other places. So it's a great question to ask to get some peer learning from other sites who have been able to do that. And sometimes you have to break down some of the stigma to be able to do this, like some of the harm and things like that. Like there might be ways to break down some of that information as well. So we're going to talk a little bit about continuous quality improvement. And so implementing continuous quality improvement processes are another piece that we discussed briefly, but really thinking about the areas that need more attention for implementation. The Plan, Do, Study, Act would fall under this, ensuring that the CQI groups are sharing out results and that information is, being shared to continue the processes for this. So would love to hear from the Fairfax folks a little bit about how CQI has been developed and implemented in your county.
Lisa, do you want to?
Sure. So I just have to reiterate the piece that Dr. Taxman brought up about outcome studies early on. I will never forget, we were in one of our first community stakeholders meetings, and we had a very influential county leader. We were 1 month in, 30 days into our diversion efforts. And the question was, what is the return on investment? And we're still trying to deal with that. So I think it's so important to not only allow some time for that, but also help to manage expectations around that from the beginning. Because I wish from the outset we had put out more information about it's going to take a little bit of time to understand how the programs work and to get some of these program outcomes and individual level outcomes. And I'm thinking about one of our teams, the community response team. The team meets monthly, and early on they really did focus on implementation outcomes. How are things working, then program outcomes. And it's really taken a while to get to the point where they're focused on individual level outcomes. And the things that they thought they would be measuring early on have flipped quite a bit. So this is a team that provides outreach and engagement to frequent utilizers of public safety services. And up front, we thought, oh, we'll measure a decrease in public safety calls. Okay, well, that makes sense, except we didn't take into account things like, well, if I pick up the phone and call 911, I may or may not be calling about myself. So how is that number coded? The names are not necessarily included in all of the calls. It's the phone number. What about congregate settings where it's one number, one main number, and there may be hundreds of people in some cases that are living in that under that main number. So there were all of these considerations. And so the team really had to kind of redefine what they considered success and really change that quite a bit. And also that I want to just touch briefly on stakeholder accountability, because I think as we have, all of the programs have reported back to community stakeholders, to county leadership, some of that report out does really help with program accountability. And it helps people when they think, oh, we know we're going to have a community meeting coming up in 3 months. So we really want to make sure that we're focused on A, B, and C, or we really want to plan for reporting out to the community in X amount of time about how the program is working. So some of that feedback loop to county leaders and to the community really helps people to stay focused on some of those benchmarks and measures.
Thanks so much, Lisa. I'm just curious, and if anyone has questions, please put them in the chat. We've been answering them as we go, but please, if you have any questions, we just have a couple of minutes left here. What has the team identified in Fairfax that's worked well, and what hasn't in terms of developing these processes?
So I'm not, I just want to reiterate one of the points I made, because I thought it was such an really creative and instrumental approach, which were these implementation problem solving teams. That Fairfax uses as a way of getting interagency efforts to basically say, we have to, this is a bugaboo. We have to figure out a way to do that. And I thought, in the model, the PDSA model, it doesn't really deal with as much, what are some of the infrastructure things you can put in place. But I thought the way Fairfax has handled that really was quite masterful. So I like to use it as an example, because I think it's, really important for the organizations, but it also gets the people on the ground to have to deal with, the issues that are getting in the way of progress.
Yeah, so thank you for that, Faye. And I think that having those interdisciplinary teams that really work together to solve problems has been so instrumental in moving things forward, and really for those teams to have that empowerment to work it out. And if they can't work it out, there are other structures in place, but they really have the empowerment to try to make things work, and are given not only the freedom, but the resources, and not just money resources, but they're able to tap on, and they do, different staff members from across the county. So the relationships that have been made may start on these small teams, but they really branch out to several other agencies and organizations. And I think having the folks that are closest to the work actually come up with the solutions to some of these things and be able to try something new has really given them a sense of, we can do this, we can work it out, we can figure it out, and that we'll do it together. I mean, collaboration is fantastic, and it's also really hard. It sometimes you're full steam ahead and everything's clicking, and other times it's just really hard. And trying to pull everyone together and gain consensus. One thing I've learned over the years is I always strive for consensus, but you may not have it 100%. But are the decisions something that everyone can live with? Do people feel heard? Do they feel like they were part of the process? Did they feel like they were part of the solution? And then work from some of that content.
I think also for that team, sorry, it's also important to give people permission. So many of us in government or bureaucracies, or actually anywhere, we're not used to creativity, innovation. We're not used to thinking. And I'm not saying that as like we're all just robots, but having someone on that team who says, yes, it's okay to problem solve. Yes, fix the problem. You don't have to take it up the food chain. Let's, fix it at the lowest possible level. To empower people with that, it's just amazing how problems can be solved very quickly.
I think I also want to add one other thing. So, when you work in an agency, we always become sort of blinded by the goals of our agencies. And I think that these interagency efforts that Lisa and Laura are talking about and promoting essentially provide people to understand the role of other organizations, how their organization needs to become more flexible in order to accommodate the true nature of a problem. So I think the benefits are just untold in terms of these interagency efforts as a way of really building the future leaders who understand the issues and not just from one lens or another.
Completely agree.
Thank you. And so a few resources to share. And again, the slides and the recording will be available on the CSG Justice Center website. Some great resources out there. This is just 3 of many. Also on the tool, there's a link to a bunch of more resources. So we encourage you, if you're interested in implementation science, to check these out. Next slide, please. We have the contact information. If you have any questions for any of us, please feel free to reach out. We're happy to answer questions. Implementation of evidence-based practices is hard, but it's definitely worth it. So any questions that can be answered, we're all happy to jump in and support. And then finally, so I want to thank our speakers, Lisa, Faye, and Laura. Really appreciate all the great content that you shared today. Next slide. And if you're interested in more resources, please feel free to sign up for the CSG Justice Center's newsletter. We really appreciate you all taking the time to hear about implementation science today and visit our checklist. So thanks so much and have a good afternoon.